My name is Krych. I'm an orthopedic surgeon in sports medicine at the Mayo Clinic in Rochester, Minnesota. And today we're going to be covering the hip joint. I'm going to try to give you my efficient and brief hip exam. We're going to cover 5 different areas of the hip exam. While we'll spend most of our time, of course, focusing on the exam, we have to realize that for the hip, a history is very, very important. And 3 things on the history help me frame my physical exam. And those 3 things are location, location, location. So first, we look at the anterior hip. If patients come with pain typically in the front of the hip, we assume that's more of an intra-articular source, whether that be a labral tear, impingement, arthritis, dysplasia. Patients who present with lateral hip pain certainly can be an intra-articular source, but tend to be more of a peritrochanteric pain, such as bursitis or tendonitis. And then posterior pain certainly can be hip joint related, but is more likely extra-articular, either the proximal hamstring, sometimes ischial bursitis, sometimes the SI joint, and sometimes ischiofemoral impingement. So once you have that history element, then you can apply those to an efficient hip physical examination. So I like to start in the seated position. What's unique about the seated position for hip patients is that they tend to be pretty comfortable in this position. Now, a couple things that I observe just when they're sitting. Some patients will kind of sit off to one side. Now, sometimes if they have like a proximal hamstring tendonitis or some ischial pain, they'll often offload that side. If there's a situation where they have hip impingement, they'll want to avoid hip flexion, and then sometimes they slouch back just a little bit, and you'll be able to kind of observe that simply when you walk in and the patient's seated. And then when we look, hip range of motion is incredibly important to help with our differential diagnosis. And oftentimes what we've learned is that's best assessed in the seated position because the patient is the most comfortable. So typically on the affected hip, what we'll look at is internal rotation. So normal internal rotation is about 20 to 40 degrees. If there's less internal rotation, sometimes people have a significant block. That can either mean impingement of the hip or sometimes arthritis of the hip. And then it's nice to do a side-to-side comparison. So on this side, we're looking at approximately 30 to 35 degrees, and then we'll compare on the patient's unaffected hip. And you can see here that's fairly symmetric. We then look at external rotation of the hip. So again, looking at external rotation, typically 30 to 45 degrees is normal. More than that or less than that can mean different hip pathologies depending on what we're looking at. And again, the symmetry or lack thereof is important, but this is very comfortable for the patient and you can get a good assessment of their range of motion. From there, you certainly can do some manual muscle testing in this position. Oftentimes, again, they're more comfortable. So oftentimes I'll have the patient push out against me. If they had any pain from an abductor source, they might volunteer that they have some lateral hip pain over the side of their hip. Sometimes we'll have them push in against me. If they have any adductor pathology, that can be common in hip patients, they'll volunteer that they can have some pain, which would lead to trying to find that source with a little bit more focused palpation of those areas. But for the seated exam, I find that very helpful. So even in a busy clinic, it's important to have your patients walk. So we're looking for 2 things. One is we're looking at their pelvic levelness as they walk. And here we can see a normal gait where both extremities are loaded equally and the pelvis is level. If we have a situation where there's a coxalgic gait or hip pain, one of the strategies they'll employ when they're walking is to offload that hip joint by increasing the lurch of their body to that side. So in this case, you can see increased lurch to the affected side, which takes tension off the abductors and decreases the joint reaction force thereby decreasing pain as they're walking. Now, the other thing that we can look at is any pelvic obliquity, or specifically a Trendelenburg test. So if you have the patient stand on their good leg first, so you can see in this case the pelvis remains nice and level. Those abductor muscles on the right side are working. You can relax. Now, if we stand on the opposite affected leg, here we'll simulate a Trendelenburg test where you can actually see the contralateral hemipelvis droop a little bit because the abductors of the affected left leg are weak and can't support the pelvis to maintain its levelness. Then we'll finish up by looking at their foot progression angle. So normal foot progression angle is straight ahead. So we'll have you walk. So in this case, that's a normal foot progression angle, but we also look for out-toeing. So out-toeing or external foot progression angle would be suggestive of possibly an impingement situation or possibly hip arthritis. And then we also can recognize in-toeing. In-toeing tends to be in hips with hyperlaxity, where they might have increased femoral anteversion or possibly dysplasia. So you can learn a lot by just watching the patients walk in clinic briefly. We'll then move to a supine examination. We can first start with palpation. Sometimes I'll just have the patients ask me, do you have any sore locations around the hip? And that can be very helpful for kind of guiding the examination. But for every hip, I like to start kind of from most comfortable and then work into more of the provocative exams, if we will. So I'll typically start with what we call a log roll maneuver. So I'm simply looking at internal, external rotation, and I'll compare it to the contralateral hip as well. And typically, normal internal rotation is about 20 degrees. If we see a lot of internal rotation, that can sometimes be an indication of hip instability, sometimes capsular laxity, or sometimes hip dysplasia. We also will observe in this case that the hip has nice recoil, so that puts nice capsular tension on it. Again, a sign of a normal capsular situation. If you had a situation where it internally rotated and didn't come back with that recoil, then perhaps more laxity. We can then have them perform the Stinchfield test. So the Stinchfield test is kind of one of those time-honored tests where we have them perform an active straight leg maneuver. So we have the patient lift their leg up and then resist me, don't let me push you down. Does that cause any pain? So a positive test would be pain, and they get pain because of the active contraction of muscles across the hip joint increase the joint reaction force. And when they increase the joint reaction force, it increases the stresses across the joint. So I not only ask them, do they have pain, but it's also important to know where they have pain. So typically pain in the front would be related to the joint, but sometimes you'll pick up those referred pains either on the side of the hip or the back that can be related to the joint itself. Now you can also do that passively. So the difference between doing it passively and the active Stinchfield is here they aren't contracting their muscles across the hip joint. So this can help if you think they might have like a nerve root tension situation where they have some lumbar spine pathology and a pinched nerve. So if they had any hip pathology, this should be a comfortable motion for them. If they had any sort of radicular type of findings, this might bring out those radicular findings. So we try to get their hip up into that 90 degrees of flexion in a relaxed position. And then we can take the hip through a few different impingement maneuvers. And again, what we're looking for is recreation of the patient's pain, but also the location is important as well. So I'll typically start in straight flexion. I'll ask the patient, is there any pain there? Typically they would have some groin pain if they had impingement in that location. Sometimes it would refer to the lateral hip or the buttock. The most common impingement test is called the Fader test, or flexion adduction internal rotation. And that's where we have the hip in flexion, we internally rotate, and then we bring it up into flexion. And I'm seeing if they have any pain in that position. And again, the location of the pain is very important. And then we can also test flexion abduction external rotation, or the so-called Faber test. Some people call this the Patrick test as well. Now, if they have any pain kind of in the back of the hip, that might be indicative of SI joint pathology. So here what I'll do then is I'll stabilize the pelvis and then push down a little bit and a positive test would be pain over the SI joint. Sometimes you can get just impingement over the hip itself and where they have pain in the front. So once we go through those impingement maneuvers, then if their history brings out that they have some clicking or catching or popping or snapping in the hip, then I'll perform some provocative maneuvers to look for iliopsoas snapping or internal snapping of the hip. Now, it's common in the population. About 1/3 of the population actually has a snapping hip. Most people, that's not a problem, but when you have a patient that presents with pain in their hip, now that snapping seems to be an issue. It's almost like your check engine light is on and every click or pop or snap that you hear is now worrisome for the patient. So what I do first is kind of a passive iliopsoas snapping test. So I'll bring the hip up into that same position, flexion, then I'll externally rotate, bring the hip all the way down and then back into extension. And when you bring that hip back into extension is typically where you'll feel that pop. And then that's the iliopsoas kind of sliding over the acetabular rim. So that's a confirmatory test. Now, once it pops, then I'll ask the patient, is that painful? I'll also confirm, is that the snapping that you get? And oftentimes we can then really have a good discussion about whether that's pathologic or not. Now, if I can't produce it there passively, the next step is I have them do it actively. So I'll have you bring your hip up into flexion, around, and then down. And I'll just place my hand over the psoas here and see if we can get it to pop. So a lot of times that will bring it out. If we can't do it with those two maneuvers, then a variation of the Stinchfield test, if they externally rotate the leg and kind of lift and press straight up against me, that also loads the psoas tendon, and sometimes I can get some catching or snapping with that provocative test. So putting those three together can be very helpful for kind of finding that out. Now, if they have any decreased range of motion, particularly in extension or flexion, you might be dealing with more of an arthritic type of hip. So one other test that you can do is something called the Thomas test. So in the Thomas test, we're looking for a hip flexion contracture. So a Thomas test, I'll have you grab your knee to your chest. And a normal test would be if this leg still stays straight on the table. A positive test would be if the hip remains in a little bit of flexion. So that's just looking for a hip flexion contracture. And one other thing that we can do, you can relax. And then two other tests that will finish up the supine part of the examination. So one is a more directed test for the SI joint. So if someone has more posterior pain that really isn't provoked with a lot of the hip impingement maneuvers, then you can do something called the thigh thrust test. So here we're bringing that hip into the 90-degree position and we're loading the ipsilateral SI joint. So I'll simply push down, and a positive test would bring pain over that same SI joint on the same side. Any pain there at all? And then finally, in a high-level athlete, you may have something called a sports hernia that can really overlap quite a bit with hip impingement symptoms. So they would give you the history. Maybe they have pain with their abdominal workouts or doing sit-ups or some other really things that load the rectus abdominis muscle. And what a sports hernia is essentially it's a tear of that rectus abdominis from the pubic bone itself. Anatomically, that rectus is actually in continuity with the adductor longus tendon. So if we're able to load the adductor and the rectus together, pain with that maneuver should warrant consideration of a sports hernia. So I have the patient typically bend their knees up, and then I'll have them press in against me and then do a sit-up for me. Any pain with that? No. So typically a positive test would be pain right along the pelvic bone, and then you could also perform directed palpation in that area if they had pain with that maneuver. But that's pretty much the supine hip examination from that standpoint. So in a patient that presents with lateral hip pain, often it's very helpful to do a dedicated lateral hip exam. And I find it very easy and comfortable for the patient to be in this sideline position. We already had them walk, so if we look for like a Trendelenburg type of sign, that may be a sign that they have some weak abductors that would also lead you to do a more dedicated lateral hip exam. So I first began with palpation. So we're looking at the trochanter. The anterior part of the trochanter, anterior facet, is where the gluteus minimus comes in. So if they have tenderness to palpation in that location, that's more indicative of tendinopathy or tendinitis of that tendon. If we see more lateral facet or superior posterior facet pain, that's where the gluteus medius inserts and can be more indicative of pathology in that location. And then the most common, patients will be sore right at the posterior aspect of that trochanteric facet. Now that's really a bare area. There aren't any muscles or tendons that insert there. So that's more indicative of trochanteric bursitis. So you can be discerning with that exam. If any pain is elicited in those areas, then we'll also test muscle strength in those areas. So if we have the patient bring their legs straight up, resist me, don't let me press down, we're testing the gluteus medius muscle strength. Then we'll have them flex their hip forward, press up. Any pain with that? So we're testing the strength of the gluteus minimus. And then if we have the hip come back and we go straight up again, now we're testing more gluteus maximus. So we can be really discerning, and that can help with our differential and sort out what we're seeing in terms of their symptoms. So once we complete that part of it, then there is something called an anterior apprehension test in the hip. Is traditionally described in the supine position. I find that very uncomfortable for patients, so I modify it and perform it in this lateral position. These are hips that you would typically suspect instability. So they might in-toe on exam a little bit. They might have increased range of motion with your exam. They might volunteer a history of instability with certain activities. What we're doing is replacing the hip in extension and external rotation. We're actually trying to lever the femoral head out of the acetabulum. So we have the patient relax, and I tell them, I verbalize, I'm going to move your hip back and I'm going to rotate it, but I'll take control of your leg. So I bring the hip back and I externally rotate. And a positive test would either be pain in front of the hip, or they would tell me it feels like it's going to come out. It's going to feel unstable. So that's typically a positive test for anterior apprehension. And those are the tests that we complete in the lateral part of the exam. So once we have our lateral exam done, then we'll move to the prone position. Now, I don't do a prone evaluation of every patient, but if they're giving you the history of posterior pain, that warrants a more dedicated prone evaluation to look for sources of posterior pain. Kind of in your differential, three of the things we see most common are, one, we do see SI joint pathology, whether that's inflammation or arthritis. We see a lot of proximal hamstring tendinosis or sometimes acute tears. And then we see something called ischiofemoral impingement, which is abnormal contact between the lesser trochanter and the ischium. So I first start out by asking them where their pain is. So a few common areas of palpation will be along the SI joint. So sometimes that will elicit pain in this location. If they have more buttock pain, then I start with the hamstrings, and I'll move along the hamstring tendon to see if there's any pain in that location. I'll then ask them if they have any kind of sitting bone pain at the ischium. So I'll press directly on the ischium to see if they have any pain in that location. And then I'll have them bring their heel back to their gluteus here to resist me. And then you can really see once the hamstring is activated, I'm palpating to see if that's in continuity or if there's any pain along that posterior chain of the hamstring. And that can be very helpful. In terms of dynamic exam in the posterior kind of buttock region, we will test for that ischiofemoral impingement. And the way we do that is the hip is in extension, and then we'll actually externally rotate their hip. And a positive test would be pain right in this location where the ischium and the lesser trochanter are abnormally contacting. Now, what lives in that space is the sciatic nerve. So sometimes you'll elicit actually radicular symptoms kind of down the leg, kind of pins and needles sensation with that examination. So that can be very helpful as well to elicit the cause of that posterior pain. I'd like to show you some of those dynamic impingement maneuvers that we just did on a model. So first of all, we'll show the prone position. So in the prone position for this ischiofemoral impingement, what we're looking for is abnormal contact between the lesser trochanter and the ischium itself. And again, the sciatic nerve runs right in this location. So the maneuver is we're taking that hip into extension and external rotation. And there can be actually abnormal bone contact, or sometimes it's just the pinching of the soft tissue and nerves in that location that will cause sharp posterior pain. In terms of the front of the hip, some of the impingement exam maneuvers that we did, what I did on this femoral head neck specimen is I just drew where a cam lesion or impingement lesion would be. So we'll just take you through some of the common anterior impingement tests. So first of all, we took the hip in straight flexion. So straight flexion might cause abnormal contact between the anterior inferior iliac spine and the base of the femoral neck. So we call that so-called subspine impingement below the spine of the AIIS. The most common test, again, is the fader, which is flexion, adduction, internal rotation, and that typically will load or bring that abnormal collision between this cam lesion and the edge of the socket. But that's the most common test. Now, depending where the cam lesion is, sometimes if we'll have a more posterior cam lesion, then that flexion, abduction, external rotation can really load the cam lesion against that part of the socket. So we're just looking for some specificity in terms of where that anatomy impinges in the hip joint itself. So thank you again for your time today. My name is Krych from Orthopedics and Sports Medicine at the Mayo Clinic in Rochester, Minnesota. I hope you've learned from our time together the three most important history elements of location, location, location. That anterior, lateral, or posterior location will then guide your exam into 5 efficient parts, including watching your patients walk, a seated exam, a supine exam, lateral, and finally prone. Once you have that information, you've developed a good differential and now can look at your imaging findings. I hope this has been beneficial. I look forward to seeing you soon.